Andrew Schorr on location at the American Urological Association meeting in San Francisco, where one of the topics that is discussed is bladder cancer. Now, I'd like to tell you there's been a great deal of progress made in this area. Not so yet. We're hoping for that. But in the meantime, there's always incremental change, and it's so important you consult with a specialist in bladder cancer. We've had the opportunity to interview one such doctor, and that's Dr. Bruce Malkowicz from the University of Pennsylvania in Penn Medicine. Bladder cancer, where are we now? First of all, in your discussions here at your meeting, your convention, anything new or where are things headed?
Well, in bladder cancer, I think there's a lot of issues with awareness and then looking where we're going to go in the future. In terms of new things, actually, we aren't moving as far ahead in this disease, and those of us who deal with this a great deal are aware of it. The basic patient awareness of these things, the basic public awareness, and the commitment to research dollars and to innovation are somewhat limited. Although even at this meeting we have seen some very new things. Just recently there was the acceptance by the FDA of newer modalities of actually imaging the bladder that may help with resecting bladder tumors. And we're looking at, again, our evaluation of surgical specimens, how we can get more information from that, how we can treat advanced disease more aggressively or at least stratify these patients better. And then hopefully along the line we'll find more in the way of novel therapies to really push the ball ahead and move our patient survival and recurrence rates in the right direction.
So I know we'd like to talk about a breakthrough. There's not one to talk about now, but better imaging to help you make decisions. A key area of decision making is whether the bladder cancer is spreading to the muscles. So how aggressively do you treat it? And when you do, sometimes it can be a very extensive surgery. Where are we now in decision making on whether someone needs such aggressive treatment?
Well, that's really a critical decision, because the difference between non-muscle invasive bladder cancer and bladder cancer is a major threshold. Because when you're stepping over and saying, I'm going to lose a major organ, an organ that deals with the storage and emptying of urine, and that's something you don't think about a lot because it seems like it's not a big deal, but when you really go back and think about the entire issue, getting control of your urinary system is one of the last acts that really make you an autonomous person. It's one of the first things that really make people very dependent near the end of their life. So to lose an organ like that is a real big deal. And what you want to do is evaluate this disease not only by a review of the pathology that may have been done at another institution, also re-resect these patients, because our pride is no longer in our way. We know that we can't do a perfect resection of a bladder tumor all the time. It's like trying to scrape out a tumor, scrape out the inside of a balloon without perforating the balloon. And it's subtly more difficult than you would ever think. So you want to get down, get the tumor out, get into the next fibrous layer that we call the lamina propria, and even get some muscle tissue there. And whether or not that was fully resected the first time, whether there's residual disease or even whether there's worse disease, all help us kind of stratify the patients. Can we give you some sort of medication that can preserve the bladder, cut down on recurrences, and more importantly, maybe even cut down on progression to this disease spreading into the muscle? Or, if it does look like it's deeper, whether or not there's more tumor there or not can tell us whether if we go into something like chemoradiation and bladder preservation, or what we're going to get with different chemotherapy, it's predictive and how much residual disease and what type of disease we have there. So there's a lot of thinking and decision making that go into what your next step is going to be. There's some people, removal of bladder, maybe simple reconstruction, maybe complicated neobladder reconstruction is the right thing. For other people, maybe radiation therapy and chemotherapy. And fortunately for a lot of the people, giving them some medication, either immunotherapy in the bladder or standard chemotherapy in the bladder, will allow them to preserve the organ and to be observed.
All right. It sounds somewhat complicated, and it doesn't sound at all like you're someone who rushes to do extensive surgery on someone. So it would seem that it's important if someone receives a diagnosis of bladder cancer, they go to someone such as you at a comprehensive cancer center and where there's a lot of experience.
I think that's true, because not only looking at this from the paper you have in front of you, from the material that you're looking at how much you do in the terms of resection of these tumors and how careful you are with that, but also everything that goes into the backdrop. You have people in pathology who are experts in looking at genitourinary pathology. They come in every day. They look at prostate, bladder, kidney, tissue, and many times it's very subtle when you look at how deep did that tumor grow, how far has it extended. And people are good at what they do every day. And then the radiation oncologists are very interested in looking at bladder preservation modalities. And then we have people in medical oncology here who are absolute experts in transitional cell carcinoma. That's a fancy word for most bladder cancers. And we'll have national reputations in developing chemotherapy for patients with this disease. In fact, about 10 years ago, we worked together to develop the type of chemotherapy that could be used in patients who have some renal insufficiency. Their kidneys aren't working that well, but they need some chemotherapy. And just recently, they've completed some earlier work on looking at second-line therapies after the things that we use first, and then the disease unfortunately comes back. Is there some room for some other therapies? And some initial pushes have been made by the folks in medical oncology at Penn. So it's a team effort in really looking at this disease and thinking about it a lot.
Now, anyone who follows cancer knows that in some cancers, breast cancer for example, they're studying the biology and seeing it as different diseases and treating it differently. Where are we now with that sort of testing in bladder cancer so that someone can have a very individualized, personalized, if you will, approach?
Personalized medicine in bladder cancer is really in its infancy right now. I think what we're doing is taking the basic things we have, like we were talking about, looking at pathologic features, looking at grade, looking at whether or not it's into the lymphatic systems or the blood vessels, looking more carefully with different types of imaging, how extended things are, and trying to really get a feel for these patients. Early tests in looking at the molecular biology have been started. In fact, we participated in a large national trial looking at some of the cell cycle of things that control how cells divide, and p53 markers and other things that were prospective studies. We're still awaiting that data to mature. But whether or not that's going to turn out to be the marker, or are we where we want to be with our breast cancer compatriots, we are not there yet. And that goes back to the lab. I mean, we deal with basic research too in our institution. We've had some initial gene discovery and other work. And again, when we have the time to do that and work to develop teams to do that, I think that's where that's going to develop on a bigger level. And those of us involved in kind of consortium groups, those of us who are involved in bigger what we call the bladder cancer think tank and other areas are acutely aware of this and trying to develop our next steps into sort of getting into this and providing our patients with that type of information. But we're not there yet.
So we'd love some clear answers. Unfortunately, we don't have them yet. You're working on it. But it sounds like at a center such as yours, there's at least wisdom of experience, and that you welcome people coming for a first opinion or a second opinion to try to help make a decision that's right for them.
Absolutely.
Dr. Malkowicz, for some people it does come to losing their bladder and they need surgery, extensive surgery. Tell us about where we are with that in your experience.
Well, what's happened in that area, there was really a big revolution in the early 1980s in saying that taking the bladder out and just finding some simple way to divert the urine, for the 1950s that was fine. It was about as the first big move that we had. But then people started looking at the issues, how can we be reconstructive and rehabilitative as well as therapeutic? And the work of a lot of people really led to the construction of what we call neobladders, and essentially using bowel segments to form pouches where you can store, and in many cases, empty the urinal, similar to the way you are when you urinate and voiding, or sometimes having to catheterize a small, very discreet little stoma, not something that would have an external collecting device. And I was fortunate enough to work with some of those pioneers and been doing this type of work since the mid-1980s, and we're able to offer patients a broad range of different forms of diversion, from the very simple, straightforward ileal conduit to work that we've been doing since 1986-87 with actually putting a pouch in the same place your bladder was, an orthotopic replacement, or something that's brought up to the skin we call a cutaneous continent diversion, and actually have done well over 200 of those type of procedures over the past several years, and have a large group of patients who can not only be taken care of in terms of their cancer surgery, but after they recover, return to almost this normal quality of life and living state that they had experienced preoperatively.
There are gray areas, as you hear, in who needs treatment when and with what, and so it is always advisable with a serious illness like bladder cancer to get a second opinion from a knowledgeable specialist. I'm Andrew Schorr on location in San Francisco. Thanks for joining us.